Good morning, everyone. Welcome to Webinar Wednesdays. I'm Maria Maddox, and I will be one of your facilitators today. Our topic will be on, is it a language delay, language disorder, language difference, and intervention or not, presented by Shauna Ruzich. We will, as you can see, I'll let Shauna introduce herself here in a little bit, but Shauna, this is the third of a series that we've been doing in webinars on speech and language that Shauna has been presenting for us, so we thank Shauna for giving us her time as well. Also, for moderators today, again, you have myself, Maria Maddox, and stepping in for Susan, who cannot be with us today, is Christine Spence. And so, Christine, if you just want to say hello to everybody real quick. Or maybe later, we'll let Christine pop in and say hello to folks as we go on.
This is Shauna Ruzich, and I'm a speech-language pathologist, and I've been in early intervention for about 20 years now, and I'm a consultant with the EI training program. So you may have participated on my previous 2 webinars. So some of the information I present today may look and sound familiar, but it is relevant to today's discussion as well. And I truly believe repetition is always good. So we have a lot of new information as well, but I just wanted to preface that. And I hope after today, that you'll learn a lot, and our objectives are to compare and contrast delay and disorder and difference, recognize typical versus atypical language development, and identify some strategies for home programming versus intervention. And we have a lot of SLPs joining us today. And as everyone knows, for language delays and disorders, the SLP is the primary person to evaluate and intervene for the most part. But as an early interventionist, we work as a team, and we would expect that everyone incorporate some of the strategies with children and families. So I thought this was an interesting statistic, and I posted it on one of my previous webinars. But just how so many children have communication difficulties, and this is from the National Institute of Health. We do have to bear in mind that children learn at different rates, and some have extensive medical and social history with anticipated delay or disorder. We have to consider cultural and ethnic and socioeconomic differences that can impact a child's language development. And others, again, it's individualized, have a very nurturing and language-rich home environment, and others, maybe it's exposure that impacts and causes a language delay. But there's no root cause many times for what appears to, cause the delay. So we have to ask ourselves why, and discerning the why is often a key element in supporting the family. So language disorders are different than a language delay, and we want to talk about and clarify these definitions a little bit further. So a language delay is when a child is developing speech and language in the same typical, usual pattern and sequence, but it's just later developing. It's happening at a slower pace. In a language disorder, the speech and language may not develop in a typical pattern or sequence. There are generally atypical difficulties that we're observing. So you'll notice those differences, and they're often, there's something peculiar. So delay, disorder, or difference. Delay and disorder often get used synonymously. And working with young children in EI, it isn't always easy to determine whether it's a delay or a disorder. And more often than not, a disorder may not be determined until a later age. Not always, but many times we're not defining the language difficulties as a disorder until we have more information, until they've received therapy, until they're possibly school age. So this is a language disorder, as you see from the reference here, is a significant discrepancy in language skills compared to the normative standards for a child's age or developmental level. Now, this is where it's important to further define and analyze what is meant by a significant discrepancy. In EI, we tend to again refer to a language delay versus disorder in most situations, but without overanalyzing it, it may not matter too much what we call it, a language delay or a disorder, but it can be very alarming to parents. Whether we call it a delay or disorder, you know, we have to be very sensitive when conveying information to parents. A delay is scary, but when you say disorder, that sounds much worse. So you have to remain sensitive before it comes out of your mouth, and just realize the impact you're making. In fact, we said, you know, a disorder may not be determined until a later time. And regardless of a delay or a disorder, a child may still need intervention. So I thought it would be a good reference, if I'm sure many of you are familiar with this, but just to have a definition, you know, of a language disorder, it would be good for you to look at this if you aren't familiar. So the DSM is what it's usually referred to, is the Diagnostic and Statistical Manual of Mental Disorders, and it's used by healthcare professionals in the U.S. and a lot of the world, actually, as an authoritative guide to diagnosis of mental disorders. And if you look at it, you'll find that it will define, you know, a language disorder. And when assessing children, you know, it's important to have that reference and to understand, you know, what does research say and how can we define it. So I did want to reference that there are some changes from the DSM to the DSM-5. So they have called it language disorder, where it was expressive language disorder, mixed receptive disorder. So I think it would be good, you know, for you to just look at this and understand what the definition is. On the next slide, it defines it as persistent difficulties in the acquisition and use of language across modalities, spoken, written, sign language or other, due to deficits in comprehension or production. Language abilities that are substantially and quantifiably below age expectations. So when I look at this, I pay attention to, you know, the persistent difficulties in the acquisition. So if you recall the definitions of delay and disorder, a child with a delay will likely catch up, but a child with a disorder may continue to have difficulties, whether it be with receptive or expressive language or both. And there are generally atypical characteristics noted, with slower progress observed and continued difficulties as developmental expectations increase with age. So that key word in my mind, the persistent difficulties, really helps us discern, you know, delay versus disorder. So a language difference. A language difference is a rule-governed language style that deviates in some way from the standard usage of the mainstream culture. An accent or a dialect, for example, is simply a difference, not a disorder. And we're, in EI and in many settings, but in EI in particular, we often see children who are exposed to more than one language. So differences can also occur in acquisition or use of the English language. For example, a child whose primary language is Spanish and is referred to EI for a speech and language evaluation. So in contrast to an impairment or a delay, a language difference is associated with a systematic variation in vocabulary, grammar, or sound structures. So we need to be very aware of that culture and the sounds that exist, the regional dialects. There's so many things to consider when you're trying to determine, is it a language difference, a delay, or a disorder. There's a nice article, and again, I don't claim to be an expert on bilingual assessment. I just thought we would discuss this a little bit as it pertains to being a difference, and I just wanted to provide some information and resources for you to further read for yourself, and I thought this was a good article from the ASHA Leader. As our population is changing and becoming more diverse, we are faced with a challenge, if bilingual children have expected language skills given their age and their language experiences. So we have some challenges with bilingual assessment, and that is there's lack of developmental information about languages that the families speak. There's lack of information about the rate and the order of bilingual language development. Again, this article has a lot of information on it. So some of the information in the article in the ASHA Leader does refer in reference to SLPs within the school setting, but I would imagine that we would run across, many of the same difficulties in early intervention and in other settings, and the data would be very similar. We know that we should consider both languages of a bilingual child when conducting an assessment. But only about, and let's just say this for the school clinicians, about 8% report having training in bilingual assessment. Again, I think that this would carry over, into early intervention, and only about 5% of SLPs report that they use a language other than English. So in early intervention, if we don't have that SLP who is bilingual, or for that matter, other disciplines who evaluate bilingual children, if they're not speaking that same language, we often have to use an interpreter. So just to highlight, the best case scenario, would really be testing the child the testing being conducted in the child's primary language, it being comprehensive, including a language or communication sample. And I thought that this was a nice article too, if you can look at the link there and capture that. It's asha.org, and this was an SLP by the name of Leisha Vogel, V-O-G-L, and she provided some nice tips for the monolingual SLP when evaluating a bilingual child. And we do this in general, but these were some nice tips, conducting a family caregiver interview, which we can gain a lot more information about the family's culture and their language in particular. Understanding how others in the family view the child's communication, the expectations, and what deficits, causes for the deficits, and do they differ significantly from the others, that are in that same communication circle. Using an interpreter, we definitely have to do that many times in early intervention. I like to work with the interpreter ahead of time, if possible, and get some information prior to doing the evaluation, because they've often met with the service coordinator, and that way you're more prepared, when you go in, and have more knowledge about the family, the individual, in just some perspective. They might tell you, it was really hard for me to understand the child, or this is what I observed, or this is not, the family told me this wasn't typical of their culture, or this dialect is slightly different. So there's a lot of challenges and variables when conducting bilingual assessment. So using a highly pragmatic test, well, we have some challenges in early intervention, and especially with children who aren't talking. If a child doesn't have much language at all, or if we do have limited testing tools that are approved in early intervention, but we do know that language is very social in nature, regardless of the language. So the best thing is to try to acquire a language sample if you can, and use a test that's going to support that and give you as much information as possible. When a child becomes more school age, I think there's other choices, but we do have challenges in early intervention. So in also considering dynamic assessment, again, in early intervention it is a little tough, and what this is, dynamic assessment is involving like pre-testing of a skill, trying some intervention to address that skill, and then a post-test to determine if there was progress, because this really helps to determine, okay, is this an impairment or is this truly a difference? Now, we don't always have the luxury in the way that our authorizations are written. However, I think you can get very creative in capturing information, pre and in the way that the auths are written to try something out, to really help you make a better assessment of the situation. Again, the ASHA website has a lot of information. You can look more on dynamic assessment. And as I said earlier, including a communication sample. How does the child use language? If it is in conversation, trying to capture as much of that to determine, is this a difference? Are they understanding English? Which language are they using more? So these are just some tips to consider. Again, I'm not the expert in bilingual assessment. Probably more people on the phone know more on the webinar than me on that topic. But I just wanted to capture some of that because it is very important to determine, is this truly a delay or is it a difference? Is it, exposure? So we've got this silent period, and we have to remember this. Regardless of the language, you have to consider the situation. If a child has been adopted from another country, they've not been exposed to English. So the silent period refers to a child first being exposed to a new language. And typically this period ends between 6 months to a year. And there's often some common misidentifications in this phase. As extreme as autism or selective mutism, and even language delay. It could just be that they need the exposure. They need to be absorbed within the culture. So just be aware of that silent period. again, this was on that same ASHA blog, if you want to take the website here, and it talks about bilingual development is recognized in 2 stages. Conversational language, I thought it was pretty interesting, typically takes 2 to 3 years to acquire, as we know, and we need to be aware of that silent period, that it could actually, take longer. And then it talks about academic language taking 5 to 7 years to develop. And there's misidentifications during these phases as well, where children get diagnosed with language disorder and specific learning disability. So just be very aware as you are evaluating children with a different language. Okay, I think this brings us to a point where if there are any questions or comments at this point.
Okay, thank you, Shauna. There was a couple of questions, and I think I gotta get to here. Just clarifying again the importance of the difference between a delay and a disorder when working with families.
Yeah, I think that just being very sensitive, to using the terms. A delay doesn't sound as scary. A disorder does. Now, it may exist. I'm not saying to, sugarcoat it, especially I think families are more accepting if they know that, okay, my child has an underlying medical diagnosis, and so then it's more obvious, okay, there's a language disorder here. But just bear in mind that, there's a lot of crossover between delay and disorder, and just trying to remember the difference between a delay and a disorder, in that a delay is a child is developing more typically and seems to be on the right path and is making the progress, where it's much slower with a disorder and there are a lot more atypical red flags.
Sorry, as you were talking, I was just kind of going back to that slide again. Maria from Joliet is curious as to whether or not the DSM-5 is the source for all diagnostic speech issues, perhaps, or are other sources used? So I'm not really sure if she's just asking if is the DSM-5 the diagnostic manual for everything related to speech, or are there other diagnostic tools? Not tools, other sources.
I know what you're saying.
Okay.
I know what you're saying, yes. Yeah. I think that it's just a very well-known, credible reference. I think that there are other resources to refer to. I think ASHA is a great site. This is just one that, it does encompass, all of, the mental disorders and expressive and receptive. And I just wanted to point out that this is a good resource when you, especially as we are required to bill, private insurance, it helps to have the definition, it helps to support using the diagnosis codes, and to really assist you as a therapist. Is it a disorder? Here's the reference for what this is. So I think a compilation of resources should always be used, credible resources.
And then Marcia wanted to know is it still considered a language difference if the child is not talking in either language?
I would say that's not really a difference. I think that would be more likely a delay, because if they aren't if they're, say the primary language is Spanish, and they're, whether it's receptive or expressive, and they're not understanding in their own primary language, then that definitely tells me there could be there's a delay there. because they're not understanding that.
Okay. Well,
it kind of depends on the situation. There's so much variability.
Right, which is true, which is why we are all look at children as individualized. So I'm kind of looking through the chat, and I don't, let's see, Paula has one other question. What are the primary changes in diagnosis of language disorder criteria from the DSM-4 to the DSM-5? So I'll go back to that slide again, and if you want to talk to that.
Yeah, let's see here. Let me get back to my notes. Let's see. Diagnostic categories for communication disorders include language disorder, speech sound disorder, so on and so forth. Well, I don't have it on the slide. Childhood onset fluency disorder. They really have changed it, let's see, from categories of expressive language disorder and mixed receptive expressive language disorder to language disorder only. So it was broken down more before into mixed receptive expressive language and expressive language to just language disorder.
Okay.
And I would encourage you to take a look at that.
Right, and just kind of a side note, up until the DSM-5, they've used the Roman numerals to designate the 1, 2, 3, and 4. With the DSM-5, they're actually going back to the actual number, the number 5 instead of the Roman numeral 5. So I don't know what the difference is. Shauna and I both looked, and everywhere it is, it's the number 5 anymore. So, all right, Shauna.
Right, so that wasn't an error, right?
Okay.
So, you know, this just depicts that language delay can be an expressive language delay only, a receptive language delay only, or a combination of both. And let's review or go over, if you've not seen some of this before, you know, what causes a language delay in children. I mean, it can be more than one factor contributing. There are some very obvious ones, and then there are very subtle ones as well, or just unknown causes. But there's autism, and there could be psychosocial factors such as neglect. Even the lack of exposure and stimulation can cause language delay, hearing impairment, just intellectual disabilities, just different things, you know, causing that language delay in children. It's very individualized. Who is at risk? Well, this statistic says the U.S. Preventative Service Task Force identified risk factors for language delay, being male, having a low birth weight. We often see, you know, our children that are born premature having language delays. These are just some that are at risk. What are the symptoms of language delay in general, and not, you know, and not in its entirety by any means, but not babbling by 7 to 9 months? People may have, you know, differences of opinion there. I mean, we definitely know the norms on, you know, babbling should be happening by 6 months, but I would become even more concerned if they're not by 7 to 9. Not talking. Now, this is general. By the age of 2. Of course, we expect them to be talking before that. An inability to speak in short sentences by age 3. Difficulty following directions. Poor pronunciation or articulation. Difficulty putting words together in a sentence. Leaving words out of a sentence. These are just some symptoms. So speech and language disorders can be congenital, meaning they're present at birth or acquired after birth. And it's usually considered congenital if it's shortly after birth. I know Maria and I had that discussion. you know, within a few days of birth, you know, something happens, or early childhood, but most of the time in the later years, it's more of an acquired language delay or disorder. So some of the causes, you know, include hearing loss again, neurological disorders, brain injury, drug abuse, physical impairments such as cleft lip or cleft palate, vocal abuse or misuse. Sometimes it's environmental stress. Again, exposure and those psychosocial impacts on language. So just to name a few. And we always, you know, have to consider many, many things in evaluating and assessing our children. And the term evaluation is used in early intervention when eligibility is determined. And then there's also assessment, you know, and that's happening at all times and throughout intervention. We're always assessing the children. It's used, you know, throughout, like I said, intervention. It's also used at the annual interval for redetermining eligibility. In early intervention, we rely on our testing tool, our observation, caregiver report to determine any language delay or disorder. And it's important to look at all the facts to determine if intervention is necessary or not. So a comprehensive evaluation should include a thorough birth, medical, and social history. You have to consider that primary language. How many languages are spoken in the home? Has the child been in foster care, adopted from another country? What is that family history of speech, language, or developmental delays or disabilities, including mental health? You know, who are the caregivers? Is the child being cared for at home in the daycare? Is it the grandparents or foster parents? Is it a temporary situation? Environment and exposure, as I've mentioned. What is the physical environment like? You know, how many times have you been into a home and, you know, the curtains are drawn and, you know, it might be very loud and overstimulating or understimulating in the reverse. So you have to wonder, you know, how much stimulation or interaction is the child getting both inside the home and then outside the home with community activities. What you're doing is trying to get a glimpse during that evaluation of what daily life is like for the child. So you want to have the parent or the caregiver describe. You want to ask open-ended questions, ask if they agree or disagree, ask if it's typical or not. And we have to determine, based on all of this information, is this child eligible for early intervention? So eligibility is, in early intervention, is having a delay, a 30% delay or greater in one or more areas, and that qualifies the child for early intervention. The services, the frequency, and the type of services are determined at the IFSP. So the SLP is considered the expert in the area of language development, but as an early interventionist, you should be competent to carry out some of the strategies to facilitate communication. So no matter your discipline, I feel like every opportunity is an opportunity to communicate. And we have to entrust in our parents. The parent is the expert on his or her child, and we guide and we coach the family. So based on all this information, we have to decide, is this typical or atypical? And this is a big question to, you know, we have to think about. So what is the norm? You know, having the familiarity of what is typical for language development will help you make a better assessment of the child, and you are using your clinical opinion along with your tool and everything that you've gathered to determine, did you observe things that were atypical? What did those red flags look like? And how do you think it's impacting that child on a daily basis? So just the next couple of slides are, just milestones. There's a lot of nice references out there, but we're not going to spend a lot of time on this, but this particular one comes from How Does Your Child Hear and Talk on asha.org. And so I think it's a nice reference, and something that you can go and you can print out and you can share with families. So they have some nice handouts on that website. So knowing what is typical, will really help you identify, and those atypical difficulties, those red flags will stand out more. So, a lot of times, we'll recognize those atypical things, and they'll be very obvious, but sometimes you really have to dig, and you have to look at everything that you've gathered. One atypical sign, for instance, is, the mom or dad or caregiver says, he or she just really seems to be, in his own world. He wants to play alone. Other things I've observed, a child just not really responding to verbal directions and requiring a lot more cueing to respond, attention, and being very distracted, or other atypical signs. I've definitely, observed children where I have to say things multiple times, and so I like to, reassure what I'm observing with the family, and I try to get situations. Do you see this? Is this what happens on a daily basis? And I try to get examples that will help me determine, is this child having, difficulties understanding language? So other signs of a receptive language delay or having difficulties would be, not responding to his or her name, ignoring spoken language. I mentioned, those difficulties in gaining attention, following verbal directions, repeating questions rather than answering them, answering questions, incorrectly or just way off, using echolalia, so repeating exactly what you're saying, difficulty processing that information. These are just some early signs of a receptive language delay, or one that could mean, a disorder. So expressive language delay and disorder. These are also some, not using many words, a limited vocabulary, frequently grasping for the right word, using the wrong words within the context. Inability to come up with what they're trying to say. Relying on rote or learned phrases. Relying on short, simple sentence construction. All of these, as you see I have in this slide, delay or disorder, these can be signs of either. It's a matter of, the child may need intervention because there are significant, differences in your testing scores and what you're observing. So it's not a matter of whether you're calling it a delay or a disorder at this time. It's just that understanding that, again, a delay is one that, okay, they have a significant, delay right now, but as you work with them for, even a short period of time, they're developing, at a nice pace. They're really getting it. They still needed some intervention, but then on the other side, the kids that end up having more of a language disorder, again, they're slower at the slower pace of progress or more atypical signs. So I saw someone's question, come up. So just these are just things to bear in mind. Are you seeing these things? And I'm trying to decide, during my evaluation as an interventionist, do I need to provide intervention at this time or not? What are we seeing? So at this time, we can pause for a couple questions before we move on.
Okay, Shauna, it looks like, kind of going back a little bit, there was a question about if a factor for language delay would include birth order. So, for example, a child having older siblings that talk for a younger child.
That is something we hear very often. I think it can have some validity, but on the other hand, the child should be talking regardless. I think that a lot of times families are looking for that excuse, if you will, and they're living in the same household. I think the strategies that you maybe suggest could look different for that child. You could have an older sibling, just demanding, more of the attention, and the younger child, not having the opportunity, to speak. So giving them suggestions and trying to encourage the older child, to let the child speak. And, so I think it's the way you go about it. But they should be learning and absorbing and using language regardless.
Could you just clarify what you mean by vocal abuse? We see some folks in the notes, but just vocal abuse or misuse.
Oh, sorry about that. Yes, it's we talked about those environmental factors and it causing more of a speech disorder, vocal disorder, more so. So it could be that a child is crying and screaming. That is an example of vocal abuse and misuse, because over time you can end up harming your vocal folds. And, like singers that, you've heard, they've been singing for, and abusing their voice, end up with vocal nodules. It can happen in young children too. So excessive crying is a good example. Also environmental, like being exposed to smoke consistently and, heavy smoke, it can cause difficulties with the voice. And I saw somebody with a question. Yes, you can have damage because of a medical procedure as well.
Thank you for clarifying that. There's also some discussion kind of going on about, and I'm not sure if it's referring to the tool or perhaps strategies in working with children who have delays and disorders. So from a developmental therapist perspective, is there a difference in approach to strategies in working with a child that has a delay or disorder? I guess from any interventionist perspective, but I think this is coming from perhaps a developmental therapist. So.
Oh, definitely. I mean, there are different strategies and approaches. So it really depends on what's going on with the child. You have to remember, with today's information, it's very general and global, and it certainly depends on what's going on with the child, whether it be, receptive language, expressive language. Is it just a delay? Are there other things that are impacting that child? And for sure. And I didn't touch on articulation in this particular webinar. We had another webinar, on articulation. So again, it's too much information to pack into one webinar.
I see there are some other questions about eligibility and percent of delay. Catherine's asking that, and Mary's kind of dittoing that as well. I know, based on what I've heard Shauna tell me what her presentation's about, I think I'm going to hold those off because I think you'll have some more clarification here as we move forward. Other than that, I think we're probably at a point where we can move on. All right.
Okay.
So we have another poll coming up, and the question is to everyone: should test results indicating a 30% delay or greater in speech in communication always indicate a qualifying eligibility? So I will add that in communication. So should that always indicate a qualifying eligibility? Your choices are yes or no. So I'll give folks a few minutes to respond to that. In the meantime, the screen is going to look a little different, so we'll give folks a chance to respond. Okay. I think this is a thought-provoking question. Yes.
I would imagine.
See folks responding in here. All right, so we are going to see what we came up with. It looks like, oh, I still have old responses up there. Sorry, folks. I'm trying to do this in a couple of different ways. I can't seem to move it, so. All right, well, it looks like it is split just about half and half, folks. You say yes, it should, or no, it should not. So what are your thoughts on that, Shauna?
Okay. Well, my opinion, and I know that everyone has a different one, so it's okay, but we shouldn't always rely on our test results to determine eligibility. It's really individualized, and you have to consider all the facts involved, consider each child and family individually. So no would be my answer. You shouldn't always make a child eligible based on that 30% delay and based on your tool. Okay, so somebody had questions about this earlier. So eligibility determination in early intervention is a 30% delay in one or more areas of development. Another way to qualify a child for early intervention is having at-risk factors, and there are several that are listed in the provider handbook, and so that's one way. We don't have very many children coming into the early intervention, I don't think, under that category. And then there's also automatic qualifying medical diagnoses. So Down syndrome, different ones. There's definitely a list of those. A birth weight, a really low birth weight is one. It's like 2 pounds, I think it is, or something like that. And so sometimes children are qualifying under that, but it doesn't mean they always need intervention. Another way is if your testing tool doesn't show the delays or the difficulties that you're observing that you feel like are impacting that child, and it doesn't show a 30% delay, then informed clinical opinion, a statement needs to be written to support that. Why do you feel that, this testing tool doesn't show the significant delays? So we're going to go over some case studies. So I want you to take just a couple minutes to look over this information, and then we're going to ask you and see what you think. Is the child eligible in particular for looking at those speech and language results?
So as you folks are reading the details here, I see that we have kind of spurred a really good debate in the chat box here. So I think as we continue on, Shauna will be able to address a little bit more about some of these things. So now that you have kind of this information, and I'm not going to switch over to the next slide because the next slide is just a poll, but the question, well, I guess I will. The question really is quickly, given the information provided, would speech and language services be necessary? So the question is yes or no. Would speech and language services be necessary based on the information that you see? And give folks a chance to respond. Give folks a few more time. I'm probably just for sake of keeping the screen current, I probably won't post these results, but I think most of you can probably see. I can tell you what I'm seeing here. So it looks like probably 75% or so of folks are saying that yes, this child would benefit from speech-language services. Would they be necessary? And another, it looks like 25% are saying no. A couple people are like not sure, and I can get that. So, Shauna?
Okay. So yes, this is a tricky one. So I see people, kind of torn. This particular child, as you can see, receives developmental and PT weekly. There are some definite atypical red flags here, but a couple of things to really take note of is that this child just started walking at 24 months, and knowing also the environment, the physical environment that the child was in, it was a smaller space to move around. The mom indicated that she was meeting all of her needs, giving her everything that she wanted when she would, grunt or whine or whatever, and so she really didn't have the opportunity to ask for things. And then as the therapist, the team, as they were talking about the child and what they had all observed, they were suspecting some visual deficits as well. So, and then let me point out too, I did note that, the receptive language delay was higher than the expressive language delay, so that was the concern. This particular SLP spoke with the other team members, and kind of based on the information, especially with the visual deficits, they decided that they would seek, further medical evaluation for the visual deficit. That at the IFSP meeting, the SLP gave the mom lots and lots of strategies, and they incorporated those strategies within the IFSP. And while the other team members were there, they all agreed that they would incorporate, the strategies, and the SLP decided to wait to intervene because she does have supports in place, and mom totally understood what she needed to do. And then the SLP decided to monitor that child and come back as needed, in about 3 months. So this child did not get services right away. So sometimes they can be very tricky, and you really have to consider all the information carefully. And depending on the family and the team members that are in place, what supports does the child have? So this is an 18-month-old boy. This is our second study, so take a minute to look at this, and then we'll talk about what you think.
So as you guys are reading the information, you will have the same question. I'm not going to make it go do that. That comes up. The same question is, do you think this child should be receiving ongoing speech and language services based on the information that you have, using the polling function up at the top, the fourth icon there, which is the polling function. You should have a yes or no. Okay. And when Shauna and I were kind of talking about this exercise, we knew that this was going to be a kind of thought-provoking and kind of questions, and kind of really thinking about how we approach services with families. And so we know that in all cases, every situation needs to be considered individually because, you know, there's so many factors that go into deciding. And obviously all we're looking at are some basic information here, but thinking about how we approach and determine when a child needs services and when we're not. So this is kind of the purpose behind these, is to kind of talk through what might be some other options available out there. So as you all are responding to should this be or should this child not receive speech-language services, it looks like, Shauna, I'm seeing again about a 75-25 split. So 75% of folks, it looks like, are saying yes, this child does need ongoing speech-language services, and about 25% are saying no, they don't think so at all. So again, need to see. I'm sure there are some folks that are still kind of on the fence as well. So Shauna.
Okay. So I would have to agree with the majority on this one, that intervention would be beneficial based on several atypical signs. For an 18-month-old, there's a history of ear infections, you know, the number of words, and the big one for me is that this child is 18 months old and is not really eagerly imitating, and I meant sounds, imitating sounds or words at this point. So those were big for me. Now, this I don't provide the answer for frequency and intensity and how long this child, you know, will receive services. I just think that it would be good to intervene in this case. And looking at the child, you know, is functioning at 12 months with a 33% delay. Some support would be warranted. Okay, let's move on to the third case study.
It's coming. It's just taking a...
No, I know. That's fine. And then for the sake of time here. Okay, so just take a minute to look over this case study. And these are real situations out there that occur every day, and I'm sure you have similar ones.
As you're reading, the same kind of question is out there, so yes or no. Lots of information packed onto one little slide. Hopefully you've got your screens expanded to where you can read those pretty well. As the responses are kind of coming in, Shauna, these look to be a little bit more divided a little more equally, maybe 60-40, 60 in favor, 40 against, is kind of the percentages that I'm looking at here. So a little bit more question about those. Mm-hmm.
Okay, so I can go ahead and start talking about this one as you guys are answering. Yes, there's definitely some risk factors here. But considering, you know, this situation, this family had adopted this child at birth. There's definitely some, you know, some concerns here. You know, the motor delays were definitely present. But during this evaluation, you know, one of the concerns that came up was in regards to feeding. And some strategies were implemented during the evaluation and observation of feeding that actually worked very well for the mom and for the child. And so, you know, and based on the mother, her response, and she happened to be a nurse and was very knowledgeable and, you know, really seemed to be on board and had lots of great questions, and, you know, just it really appeared that there was a lot of good family support there. Being that developmental therapy recommended, physical therapy recommended, the SLP, you know, felt like, okay, a lot of these skills are just starting to happen. Even though the receptive and expressive scores came out to be a 36% delay, intervention was not recommended at this time, and it was recommended to just monitor this child within, you know, 3 months or so if needed. So wanted to really, you know, give this child an opportunity to develop, and knew that there were supports in place not only with the family but also the other interventionists that would be in the home. Okay. So sometimes it's a wait and see, and sometimes it's let's intervene. I thought this was an interesting, you know, statement to consider. Although most children who have a speech and language impairment have a history of language delay, let me back up. Although most children who have a speech and language impairment have a history of language delay, only 1/4 to 1/2 of late talkers are eventually diagnosed with a language disorder. So that really helps support looking at, is it a delay? You know, are they developing in a typical sequence? How much support do we need to provide them? What supports do we need to provide them? You know, and we can argue and we can advocate to support those late talkers. It's just a matter of really scrutinizing and looking at the risk factors to decide, you know, when is it that we intervene? So just bear that in mind. And is intervention necessary or not? And as I've been saying all along, looking at, you know, your clinical interpretation of the testing results, considering all the facts, being as comprehensive as possible, then that will help you decide, you know, what services should be provided and what frequency and what intensity. And we're not going to talk about that a lot today, but just deciding, is it critical at this stage? Let's look at who's in the home, what supports do we have, what team members will be in there. I wanted to provide you with some predictors of true speech and language impairment. I thought this was another nice resource, and some things to bear in mind that, you know, these particular difficulties could result in a disorder. So thinking about those, and again, it's not a matter of is it a delay, is it a disorder, but to understand the difference and to know when to intervene or not. So just bear all of these in mind. We've talked about it even in our case histories, in the evaluation protocol that we went over. These particular predictors, you know, could result in a true impairment. So whether intervention is determined or not, parents know their child the best, and we as interventionists should be enlisting strategies that make sense, that are realistic, and can be embedded within routines. So providing those verbal and written ideas. So in the example where the SLP did not make recommendation for direct intervention. She provided the family with written strategies. They were built into the IFSP outcomes. They were discussed with the family, the caregivers, and the team members. So communicating often with those team members and having everybody on board, and you know, and just making sure that everybody's engaging and really implementing all of those strategies as a team and not isolated. So a child's development, it should really be a journey, taking one step at a time and making footprints along the way. As an EI provider, your role is to coach and guide and promote confidence in the families and the children that we touch each and every day. So I hope that you can take some nice things away from today's webinar and incorporate them and really think, you know, as you're evaluating children and assessing your children that you have on your caseload, and enlist some of these strategies with your families. So any last questions?
So there are a few, and I will be honest, trying to go back with all the other comments to weed out where some of the questions are. Just bear with me. I see that Catherine is kind of wondering if you can address about using percent of delay with disorders rather than, I'm going to have to get that question clarified. I got to find it again. How about Ellen has asked, could informed clinical opinion also include your opinion about if the child should benefit from treatment, not just if the tool is showing eligible delay? Let's see what you think about that.
Well, you should always be using your informed clinical opinion. You know, regardless of the testing tool, you should be taking into consideration all of those, all of your clinical knowledge. So you could have it go either way. You know, if the testing tool does not show that 30% delay and you feel like services are warranted, you have to justify it. But you have to consider both in EI. So 30% delay is what, you know, makes the child eligible. So I think you just have to justify it. I think you can use your clinical opinion. However, in EI, it is that testing tool. Does it show it or not?
I did find Catherine's original question, and she's asking for you to speak to how the EI program requires eligibility based on percent delay, but that this isn't really a valid measure for children who have disorders rather than delays. And I think that's kind of the crux of your overall initial question of children who have a 30% delay. Do they need speech-language services? And I don't know if those are kind of related or not, but I think the question is percent of delay when children really have a disorder and not a necessarily delay in language development.
I think if they have a disorder, you're going to see that 30% delay. I mean, again, it's not a matter of is it a delay, is it a disorder. It's a matter of using all the information, using your testing tool, using your informed clinical opinion, and determining, you know, eligibility for services. It may end up, you know, again, it's kind of hard at this age. We do see some children who have, you know, true disorders. I think for the most part we are seeing children with delays. It's knowing the difference, and I think you are going to see that, you know, 30%. I think justifying and presenting all the facts to determine, you know, eligibility regardless of delay or disorder.
I think probably what this has touched on is a much bigger issue than can be addressed in an hour and 15-minute webinar on eligibility for program and eligibility based, for necessary services, and how do they connect with each other, how do they relate, and then of course the overall bigger picture of eligibility in our state as it looks right now. So I think that's kind of probably a much bigger topic.
I do too, and I think that there are some disorders that are automatic qualifiers, so
Exactly.
yeah, I do too.
Okay, so I mean it looks like that's pretty much most of the questions, and unfortunately we have run out of time, and